And we did a pilot study, had 10 patients, all 10 had improvement in all their gait parameters. We actually even had fall risk that was reduced.
That's awesome. Which means they're not going to get a repeat fusion.
Right?
Well, I like this. This is really important.
Yeah, when you start falling, you know.
Where's that chair going to fall right now?
Welcome back to the OuchCast. I am Neal Rakesh, and I'm here with my host, Dr. Gulati.
Glad to be here. It's going to be a very exciting topic because it's revolutionary how you guys are treating things in the sacroiliac joint.
Yeah. So we're going to cover sacroiliac joint dysfunction and sacroiliac joint fusion specifically. Who have you got for us today?
I got two of my great friends, colleagues, trusted faculty, Dr. Nomen Azeem, Tampa Bay Buccaneer fan from Tampa. And Dr. Anjum Bux. Do you guys have a football team in Kentucky?
Yeah, Kentucky Wildcats.
Oh, yes, they play SEC.
He's like, how could you not remember that?
Well, it's not the NFL.
It's not the NFL.
We got the Bengals. That's our default team.
Yes, I'm pretty sure Cincinnati, for those of you who are podcast listeners, is in Ohio.
Yeah. So we got a pretty star lineup here because I'm going to admit, and I think the same thing for you. This is something that we don't know a lot about. And so could you guys explain to us what exactly is a sacroiliac joint fusion? What does that mean?
Go ahead, Nomen.
So essentially, the sacroiliac joint starts, breaking down just like everything else in your body. So you end up getting arthritic changes there. A lot of times you have micromotion causing inflammation, and essentially what that's going to do is cause pain and dysfunction. And so the fusion is it's not the first line of treatment, but it is something that we can do to indefinitely secure that joint, stop the micromotion and inflammation so that the patient gets better with their pain as well as with their function.
When you say like micromotion, before we kind of delve in, what does that mean for like a patient? Like what are you seeing in the clinic that says, hey, this is a painful sacroiliac joint?
I'll tell you, that's probably... First of all, SI joint dysfunction is probably one of the most underdiagnosed pathologies out there in pain. We've started learning more about it over the last few years. You know, patients that have had previous back surgery, that have had fusions, that come in still saying, hey, I'm still having back pain. It's usually from the SI joint. And what Dr. Azeem was alluding to with the micromotion, you know, as there's arthritis buildup and there's motion in that joint, especially kind of women that are giving birth, and pregnant women have that because, you know, their pelvis changes as they give birth to these babies, and that SI joint moves. Yeah. So as there's more movement of the sacrum along the ilium, that causes arthritis, inflammation, and increased pain.
So I agree with Dr. Bux 100%. I mean, I think that, you know, when we look at just worldwide, we're looking at about 8% of population worldwide has low back pain, right? Complaints. About up to 30% of that is due to the SI joint. So as you mentioned, I mean, it's just not something that's picked up. It's been overlooked for many, many years. And I'd add to the indications the causes, falls. Fall onto your butt is going to a lot of times cause sacroiliitis and maybe SI joint dysfunction.
Amongst a lot of other things.
Changing gait too.
I do have a question though. It bothers me is
your sacroiliac joint.
No, I'm good.
Did you fall?
Yeah, I haven't fallen.
You fall on your butt?
And I don't think any of us given pregnancy
I
either.
was going to ask how many.
I think we're good there too. But we're supposed to have the joint supposed to move. It sounds like a little bit.
Yeah.
So how do you decide how much is supposed to move and when to stop it from moving almost at all? That's been my struggle with this. Like, how do you stop a joint that's supposed to move a little bit? For certain situations, move a little bit more. So you get a baby out, for example, and then hopefully it comes back and moves a little bit again. And when does it become?
When it becomes painful, really. I mean, you know, when they start having issues with pain, and usually that pain's kind of in the buttock area. It radiates into the groin, sometimes down the leg. So, you know, when it becomes painful, you make the assumption that there's really no way to measure it really. Not that I know of. Nomen may have something, but
So, I mean, to kind of get into weeds a little bit here, the sacroiliac joint in men, it's about 1 to 3 degrees of motion. Okay, the motion is called nutation. It's just a type of rotation, and so it's 1 to 3 degrees in men, and about 2 to 4 degrees in women. The SI joint is instrumental in pelvic tilt. Okay, so when you're getting out of seats or chairs, going up steps, those types of motions and your gait, you need to have that pelvic tilt during your gait cycle. So it's instrumental in all of those things. So
and it's
what
like
is
transitional movements.
It is transitional movements.
So
You're absolutely
that
right.
changing in positions. And that's very much the PM&R.
That's the
PM&R.
PM&R.
I know, because when you said nutation, I was like, I'm right there with you.
see, I'm anesthesia background, so he's smarter than I am as far as all that
He's
concerns.
like, what's nutation?
I can numb it up, but he can detect the motion.
I'm the SI joint whisperer. Yeah. So, but to your point, I mean, I think that absolutely you need to have some motion there, right? But the motion is transitional. When I say micromotion, I mean more so that over time, the ligaments that overlie the SI joint that hold it together, they get lax.
They get lax, and that causes increased motion.
So micromotion is beyond the 2 to 4 degrees for women and 1 to 3 degrees for men, clinically, not measured necessarily, but you're assuming they're probably moving a little bit more than they should. And so the fusions are trying to bring that back to more normalcy.
Well, and that motion causes a lot of times inflammation, right? And so you get into this inflammatory vicious cycle where you're having this micromotion there just from your normal activities of daily living, and it gets inflamed. And so again, like conservative measures for SI joint, I mean, physical therapy, medication management with anti-inflammatories, injections. And then you can get to radiofrequency ablations. And a lot of that depends on payers and whether they'll pay for it. Is it experimental or not? So all those things play a role in helping this dysfunction out.
We kind of figure it out through, examining the patient, kind of figuring out what causes this pain. Usually getting up from a seated position, certain gaits may exacerbate their pain. And just like Dr. Azeem said, injections. We can do diagnostic injections to see. We do a diagnostic injection with local, and if it takes their pain away, you're assuming their pain is coming from their SI joint.
And that's an anesthesiologist talking.
There you go.
and that's an important distinction, because there are like history physical exam findings, like Laslett's clusters, for example, one of the highest predictive values for SI joint dysfunction. But even with those things, the gold standard of diagnostics is an SI joint injection. That's what you can find in the textbooks. That's what they say. Yep. So the injections are in some ways how you tell that. But
it's not just how you tell it. It's a prerequisite for getting authorizations for the fusion.
Exactly.
So you have to have 2 with at least 75% improvement reported by the patient, transient nature, and then you can move forward along with getting imaging done of the pelvis and making sure there's no other pathology that's going on that you're missing.
Makes sense.
Yeah.
What's like so let's say you decide you've gone through all these things and finally you're at the point that they don't get persistent relief from all the things you've done before. You decide to go for a fusion. How do you tell the patient that you're going to do this, and are there different approaches for this actual procedure itself?
So usually the patient tells us. I mean, we do these injections and they get great relief. And now we're limited. If you do therapeutic injections, you're limited to 1 every 3 months. And so if I inject a patient, they get they 100% better. Had one yesterday, 100% better for 10 days. And then their pain came back. What can I do to get this better? I mean, this is where my pain's coming from. We can't do another injection. We can no longer do RFA because, they're not going to pay for it.
Yeah.
So they're asking us for the next step of what we can do. And that's where the SI joint fusion talk comes into play. So that's what we talk about. There's a way that we can fuse this joint to reduce the motion, stabilize the joint to reduce your pain. And these patients are usually hurting so bad from it, they get great relief. They're all on board. So that's kind of my talk track with these patients.
So the only thing I'll add, I'm sorry, is that, for the patients that can get an ablation done, I still give my patients the option. I just put it in front of them. Hey, we could do a radiofrequency ablation and you'll get extended relief from what you're getting from your injections, but again, we have something in our tool belt that may fix this indefinitely. I mean, we have data 5 years and 5 years plus for patients that have had SI joint fusions for multiple approaches that show that it's efficacious for that long.
What's the difference between an anesthesiologist and a rehab doctor fusing versus kind of the common people that fuse things like surgeons and
common people?
Common people.
Common surgeons. Common surgeons.
So I'll tell you.
The common man.
Yeah,
common procedures.
for at least from my background in physiatry, I'll tell you that the F word is evil, right? It took me a long time.
I told that to my son too. But
I had to think about that one for a second as you said it. I was like,
No, it took me a long time to come
fudge.
around to be able to talk to patients about fusing anything, because your body is a compensatory being. So essentially you fuse one area, something else is going to become hypermobile and it's going to break down faster. With this, again, if we're just trying to eliminate that micromotion that's occurring, and really because of the limited range of motion that you have in that joint, you're really not going to break anything else down. This is not like fusing the hip joint. That would be a disaster, right? But this is not as mobile, so it works.
And we've kind of seen an evolution in these fusions where the common orthopedic surgeons doing this. It used to be a big, bloody, painful procedure. You were non-weight bearing for a period of time. You stayed in the hospital, and really you're putting big plates across the joint. And it was a much bigger procedure when orthopedic surgeons were doing it. Now, as this procedure has evolved to being minimally invasive, where through one little incision, we can put screws across the joint and achieve the same result. With pain physicians doing it, it's a lot better. My patients get up and walk out. It's an outpatient procedure done in an hour, and they're weight bearing that same day. They get up and walk out and they get great pain relief. And really, there's no post-operative pain medicine you have to give them. So
that's interesting.
The procedure has really evolved so much to where it's become minimally invasive. You're getting the same results, and patients are doing much better.
Do you ever get into a situation where the patient says, well, my surgeon wanted to put 2 screws, but instead I think these devices that are available to us as pain physicians, this is a better approach, and you discuss the two and give them the pros and cons? Do patients kind of seek these things out, or are you describing it to them?
I think our patients are a lot more educated than used to be, and part of that is social media and just all the platforms that they have access to now. So I do get a lot more patients that are coming in and asking about it, but when it comes to a choice of posterior allograft, like 1 bone dowel versus 2, or screws coming across the joint from lateral to medial, I mean, again, that F word again. I mean, people associate that with screws and rods.
Yeah,
right? And they don't like it.
Title of this podcast:
Screws and rods.
But so it's very much easier for me to talk to my patient about an allograft bone dowel that I'm going to put in the joint versus metal. Right, because then that metal bony interface is not always great.
So why is that an important thing? When you say that, just for people where we break it down basically, why is that very important that that's different?
Just most people don't want metal in their body, and so if you're talking about a cadaveric bone dowel that you're putting in, that's going to cause an arthrodesis or essentially fuse across that joint, and you have CT data to back that up, then most people would rather not get metal in their body for any purpose unless it's at like last resort. And again, I think because of the last couple of decades of the overutilization of spinal fusions, everybody knows somebody now that comes into my office on a daily basis saying, "Hey, whatever you do, I don't want that fusion. I don't want that."
Yep.
Right.
Yeah.
So,
F word.
F word. Don't give me that F word.
Yeah. And so you said this is a relatively short procedure, which is the benefit of it.
Yep.
The recovery period is obviously very easy. I'm sure, is there like a little bit of post-surgical stuff where they have a little bit of pain from the actual site that it's going through?
Yeah, there's some post-surgical soreness. But really, I kind of limit my, same thing we do for a lot of our implants. If we're implanting a spinal cord stimulator or a pump, they're lifting, they're twisting, they're bending. We kind of limit all that for about 2 to 4 weeks. They can walk, they're weight bearing. They a lot of times they get immediate pain relief. Soreness lasts about 48 to 72 hours. That goes away, and usually anti-inflammatories for that, and that's fine. So
I do think it depends on the approach.
Yeah.
I think if you're using the lateral approach, I think it is, even the minimally invasive lateral approaches are more invasive than the posterior approaches.
Okay.
You are using screws. A lot of times you're using either a power drill or a hand drill, and you're going across the sacrum, right? So I think with those, you're going to have a longer recovery. And to Dr. Bux's point, I mean, I think the posterior, whatever you decide to use, but the posterior approach is so minimally invasive that, within 48 to 72 hours, the soreness is gone. I also don't prescribe any pain meds post-operatively. And I can pretty much guarantee that with my patients that within that first week, you're going to be feeling a whole lot better.
This sounds so good. I mean, are there opportunities where you talk about patients where things haven't worked out as you hoped? Maybe too fused or not fused enough, even though you use these minimally invasive devices?
So that's a really great point. So as a physiatrist, again, the F word, right? So my job as a...
I know things are changing in Florida educational system, but...
So the idea of, my outcomes for pain relief and functional improvement, do I really care if there's an arthrodesis? I mean, for the coding, sure, but as long as my patients are better and stay better, and I never have to address this joint again, then I win, right? And the patient wins, more importantly. So I think that, it's just more so whether it fuses or not, are the patients getting better? So one of the things you can look at is, for example, we were both, Dr. Bux and I are saying that our patients do well pretty soon after the implant.
Yeah.
You don't have a fusion after the implant. It takes 6 months, 9 months, right, for it to fuse. Right. So why are they getting that relief? They're getting that relief because, again, you stabilize that joint, right? So if an arthrodesis never actually happens, a full fusion doesn't happen, but they stay well, again, are we worrying about the coding here or what's best for our patients?
Yeah, it's interesting because we started off this whole thing saying that the sacrum is essential for essentially translating force from the low back and the hip. It disperses that force, and so the goal is to still have some motion. You want to remove the abnormal, the caustic micromotion that's causing them pain. So if this approach, like you come from a posterior approach, does it still allow for the small amount of motion that you need, but you remove that caustic micromotion? Is that really the benefit?
I think that's absolutely correct. I mean, I'm part of a study that we've been looking at gait and gait dysfunction in patients with SI joint dysfunction. And then using the posterior approach, we measured non-patient reported. We had these portable kinesis devices that we strapped onto patients, and we were able to check about 32 different gait parameters. And we did a pilot study, had 10 patients, all 10 had improvement in all their gait parameters. We actually even had fall risk that was reduced.
That's awesome. Which means they're not going to get a repeat fusion.
Right?
Oh, I like this. This is really important.
Yeah, when you start falling,
Where's that chair going to fall right now? But I think this is very important because we're leaving in pain medicine, we're going from just pain scores to functional assessments. Maybe, Anjum, you can tell us a great story of a success using this that really improved function. It'd be really helpful for the listener to kind of think about this and who they can really help.
Well, that's the thing is that, when there's SI joint dysfunction, it can be caused by gait disturbance, and that gait disturbance really exacerbates your pain. So it's really a vicious cycle. Once we stabilize that joint, and I agree with Dr. Azeem, really stabilizing the SI joint is probably more important than fusing it. And as we've stabilized it, improve the gait, the function improves significantly. And I've had patients that, once we've taken that pain away, they're much more functional. They're able to do more stuff. They don't have that gait disturbance, which is exacerbating their pain. So overall, they've done better.
Seems like we should change the F word to the S word for stabilization.
I like it.
There you go. Got the F's and the S.
PH is in there somewhere.
I love that.
Yeah, I want to kind of touch on kind of is there a dark side to it? Is there something when should you be wary of doing something like this? Because with every great kind of technology and something like that, it's easy to do it in the wrong situation. What have you experienced? Are there things that can happen that you should be very wary of? And how do you know to say maybe not this patient?
So I was going to say there's some patients that I've kind of been leery of, and Dr. Azeem may have more experience with this, but patients that are osteoporotic, elderly patients, I've kind of stayed away from. kind of stabilizing or fusing this joint for fear of fracture. And those are the patients that, you can cause more damage trying to go in there and fuse this joint by creating a fracture. So those are patients that I've kind of stayed away from. Dr. Azeem kind of expound on that if you want.
Yeah, no, I agree with that 100%. I think you want to be careful in those patients. I think it's really a risk benefit thing, right? I mean, you talk to the patient about if you can't do an ablation or you tried an ablation and that was the endpoint and, it's just not an option, then I think I have a responsible conversation with my patient and say, these are the risk factors, but we can try this. But in that setting, I would not use any kind of metal anything, right? Because more chance for fracture.
Right.
I would consider something that uses a bone allograft because of the fact that you're just putting bone in there, right?
Yeah.
And still trying to stabilize that joint. And of course, take every precaution. There's been some studies done on CT mapping before you actually do the posterior.
Interesting.
Yeah.
That's
so
cool.
you can actually measure out the angles. And so when you're in the OR, you can actually measure those out, draw on the skin, and then have a more accurate trajectory into the joint.
Man, I wish I said the word ultrasound.
that would just made it better, huh?
Yeah, just
or you can use ultrasound.
Vicious point for
it's like ultrasound and then the fluoro machine.
You're looking at it very brilliantly in terms of angle of entry. That's actually the CT and ultrasound may be helpful, may not be, but I think it's great that you're thinking that way.
Well, and I think one of the barriers to this procedure has been the fact that all pain physicians, or majority of pain physicians, are trained to do SI joint injections at the inferior portion of the joint. Right?
Yeah.
But a lot of these bone dowels that get put in, they're supposed to be put in around the S1, S2 foramen, much higher up. Right. And you have to oblique much, much further, and you have to get that PSIS out of the way.
Yeah.
And when you do that, you can just ride the PSIS into the joint as well. But having something like a preoperative CT for planning, I mean, that just makes it that much better.
I can tell you that since I've started doing this procedure and operating on these SI joints, my injections have gotten much better. And, I'm getting right into the joint now, whereas I used to not oblique far enough over, not line up the whole joint, and just get in that inferior aspect. And we don't get good enough spread of medicine in that joint. So as I've done this, my injections have gotten better. Patients have really gotten better relief since I'm getting into the joint more.
And we see this in oncology. Our patients, we do our ultrasound. And it's exactly the same trajectory. We're doing the top half of the joint for our sacral fractures and those kind of things as well.
Yep.
Yeah, I think that's you could go into a whole kind of like different discussion. Like, where does pain generate from in the superior SI joint, which is the ligamentous portion, versus like the inferior, like the synovial portion?
We're serious.
I think we've covered a lot. Did we miss anything? Any final thoughts from you guys?
I mean, I think that, as these techniques get to be more refined, there's some new coding that's going to be coming out for 2024 for the posterior approach. And part of that coding will allow us to do this procedure in the office.
Oh, interesting.
That's very good.
And so there needs to be a lot more education and a lot more training so that you are either mapping or doing everything you can to safely get into that joint, because the posterior approach, one of the biggest issues, and Dr. Bux brought this up as well, somebody osteoporotic, but even if they're not osteoporotic, you can put a bone dowel into the sacrum. If you're not careful, if your trajectory is not good. And so we want to make sure that if we're going to do this in the office, that every precaution is taken so that you don't have those kind of outcomes in the office.
Yeah, I like that.
And, my final thought is really, we need to be more aware of SI joint dysfunction. Start looking at it in your patients.
Physiatrists are already.
Yeah, well, more anesthesiologists, pain doc need to be aware of SI joint dysfunction.
We're looking for falls today.
But, that's something, again, it's underdiagnosed. We need to, do your diagnostic injections. Patients, that you come in, which have had previous back surgery that are fused, they're continuing to have back pain, look at their SI joints. They may be a perfect candidate for injections and later on stabilization or fusion.
Well, I want to thank our dear friends, Anjum and Nomen, really bringing up something very new and exciting in this field and really changing the way we're treating our patients.
Yeah. Thanks for stopping by, guys.
All right. Thanks, guys. Thanks.